Mm. Today, myself Pranam Gupta, final year MBBS student. I'm here to discuss an important topic, basically eczema from dermatology. Hope you like this video. So I'm going to present my own slides. So yeah, eczema. So eczema or dermatitis is today's topic of discussion. So basically, what is eczema? First, we shall know about the definition of eczema. So eczema is a reaction pattern of the skin secondary to endogenous or exogenous stimuli which it faces. Uh, uh, so first we should know about the difference pattern, about differentiate between dermatitis and eczema. Most of it is interchangeably exchanged, that both dermatitis and eczema are of same, but these are not same. Eczema is basically a part of dermatitis, and dermatitis includes inflammation of skin, as you can see. But all dermatitis are not eczema, which is the point of highlight. Eczema can be psoriatic type and eczematous type. So in nutshell, we have to take the point that eczema is a subtype of dermatitis. Okay. So next we will talk about the morphological classification, or what we you can say clinical stages, which is acute, subacute, and chronic. So acute eczema is, as you can see, is characterized by all the signs of active inflammation of skin. Basically, you know from the pretty well about the pathology basic lectures. It includes erythema, edema, vesicles, oozing, crusting, etc. And on the histopath examination, you will see an important feature, spongiosis, which is nothing but intraepidermal intercellular edema. Now next we have subacute eczema. Subacute eczema is characterized by erythema and scaling, and next then we have chronic eczema, which happens as a result of chronic itching, and it includes lichenification. In lichenification, we have 3 points. Basically, hyperpigmentation, thick skin, and increased surface marking. Don't worry about the images. I have put the images in the end, so as for proper revision, and also I am explaining this topic in a nutshell, so it will be easy for further revision also. So first, in the below image, I have written classification also. So on the basis of etiology, I had classified eczema on the two types, basically two main headings, exogenous and endogenous. Exogenous is further divided into contact dermatitis, phytodermatitis, photodermatitis, and endogenous has many small headings also. Phytodermatitis, as the name suggests, it is plant induced, and photodermatitis, as the name suggests, it is sunlight induced. Now, talking about the exogenous first. So, in the exogenous, we have contact dermatitis. Its definition include inflammation of skin secondary to the contact between skin and incipient substances. So, basically, from the names, as the name suggests, it is basically due to the contact between the skin and the irritant or incipient or allergic substances, due to which the skin is getting inflamed and we are getting dermatological manifestations. So it is broadly in two types. Basically, we have to know is, I have written the short forms for easy memorizing: CID and CAD. CID is for contact irritant dermatitis, and CAD is for contact allergic dermatitis. So first we will look about their basic main differences, and then I will explain it further. So I had written as for the first the predisposition. Contact irritant dermatitis is affects all those who are exposed. So it does not selectively exclude, or it is not specific, but it is a generalized involvement. It can affect all of the people, Whereas in contact allergic dermatitis, it affects only those who are genetically predisposed. It does not affect everyone. Secondly, talking about the mechanism, the contact irritant dermatitis is non-immunologic. That is, it directly affects the tissue damage. It is not an immune mediated phenomenon. Whereas in allergic contact dermatitis, it is an immune phenomenon, immunological type 4 hypersensitivity reaction. In contact irritant dermatitis, it is basically restricted to the site of contact where the irritant is there. Whereas in contact allergic dermatitis, it usually, most oftenly we have seen that it tends to disseminate beyond the site of contact. Another point of difference, we can note that there is more burning sensation in case of contact irritant dermatitis due to the presence of irritant. Whereas in allergic contact dermatitis, we can see there is more of itching type. So more of itching type. In contact, now I will explain more about contact irritant dermatitis. Contact irritant dermatitis is due to the exposure of detergent and vegetable. Most commonly we have seen detergent. So most commonly it is seen in housewives. That is why contact irritant dermatitis is also known as housewives eczema. It mainly occur on first exposure, and here, since it is not a non-immunological phenomenon, so memory T cells are not formed. Its examples include detergent, acid or alkali. Basically, the highly acidic or alkali environment affects the skin. Also, there is diaper dermatitis, which involves the convex areas seen in the infant or babies, pediatric age group, sparing the folds. Now, next is contact allergic dermatitis. It is due to the exposure to allergens, various kinds of allergens, not a single kind. So it can be seen in hair dye. Uh, Hair dye, as you know, hair dye have a important chemical as a constituent known as PPD, paraphenylene diamine. Similarly, in turpentine oil, you can have colophony. In neomycin, you have is not used as a topical antibiotic, as neomycin is also an allergen. Bindi is also containing an allergen, PTBP, para tertiary butyl phenol. In cement also there is potassium dichromate. In rubber there is thorium. In tattoo dye there is cobalt chloride. And also in artificial jewelry we often see itching and this eczematous type of contact allergic dermatitis type lesion. It is due to the presence of nickel. So these are the various kinds of allergen. These you have to remember by heart. Uh, the contact allergic dermatitis is basically occurs due to subsequent exposure or repeated exposure with the same allergen. So it does not occur on first exposure. So there is also another point of difference between them. Here the memory T cells are formed, and it is basically diagnosed by the patch test. In patch test, two readings are basically taken on second day and fourth day. More specific reading is on fourth day. In patch test, basically a small quantity is placed in fill-in chambers, and small quantity of allergen is placed over the back of patient. So if the patient comes positive for that particular allergen, it confirms the diagnosis on patch test. So next main heading under contact dermatitis is ABCD. ABCD full form is airborne contact dermatitis. We have seen contact irritant dermatitis, we have seen contact allergic dermatitis. Now we will talk about airborne contact dermatitis. So airborne contact dermatitis basically occurs by a specific plant grass, Congress grass, which contains a chemical cis-quitridine lactone. So another name for Congress grass is Parthenium hysterophorus, which is a causative allergen. It occurs due to the air carrying the pollens of this plant. Basically it is a type of contact dermatitis which is caused by the release of that particular substance into the air, which settles onto the exposed parts of the skin, not on the unexposed part of the skin. Exposed areas may include neck, upper eyelid, face, V-area of face, etc. So it is basically seen in farmers and gardeners who are by occupation. And for it, the diagnostic test, as I have written, it is photopatch test, where the patch test is in combination with ultraviolet radiation. So it is basically a type of phytodermatitis. In acute treatment for it includes systemic steroid, and long-term treatment of it includes azathioprine. Azathioprine. Prevention, as the name suggests, it's try to avoid contact with the allergen, that is the Parthenium plant or the Congress grass. Now, next I will be talking about endogenous eczemas. So, endogenous eczema is numerous ones. First is seborrheic dermatitis, or what we know as dandruff. It is basically a feature of inflammatory response of seborrheic areas. That is those areas like scalp, face, nasolabial folds, or auricular region where there is increased activity of sebaceous gland in our skin. So basically, in these areas, there is inflammatory response to the Malassezia yeast, due to which there is seborrheic dermatitis. The scales are greasy yellow. Don't worry, we will see all of the pictures in the last. So it is a severe disease which can also be seen in Parkinson's disease and HIV infections. So differentials have also been ruled out. It is most oftenly confused with scalp psoriasis, but need to mention that it is greasy yellow scales containing, while in the scalp psoriasis there are silvery white scales. The infantile seborrheic dermatitis is also popularly known as cradle cap. Now next is stasis eczema, or also known as stasis dermatitis. Stasis, as the name suggests, it is due to pooling of blood or gravitational eczema. So it is basically associated with varicose vein. Chronic venous insufficiency gives rise to this. Next is asteatotic eczema. Its synonym is eczema craquelle. It's mainly affects the older age group. There is decreased skin surface lipid due to cold and lipid deficiency, also known as winter eczema or eczema craquelle. Here the lesion is itchy, crack, and there is presence of crack on skin along with the dry skin. Next, I have written pityriasis alba. In pityriasis, the meaning is scaling and alba means white. So basically, there are white scales on the face. The profile includes children. The lesions are hypopigmented, scaly macules over the face. It is not to be confused with nutritional deficiency, as it is not. Differentials include indeterminate leprosy, but there the scaling is absent. So next is nummular eczema. Nummular eczema, also known as discoid eczema. Here there are coin-shaped lesions are seen. That is, there will be well demarcated edges. Differentials include tinea. Next is pompholyx. Pompholyx, synonym is dyshydrotic eczema. Here the lesion is intensely pruritic, deep-seated vesicles. The appearance is sago grain-like appearance. The sides are sides of digit. So next, in detail, I will be talking about atopic dermatitis, which is an important topic of this discussion. So it is a chronic relapsing inflammatory skin disease. So that is, it is classified basically as an endogenous eczema triggered by exogenous factors. So first we should also know about the atopy, as it is often misunderstood. Atopy is basically the localized form of type 1 hypersensitivity reaction. So basically, any patient which presents with atopic triad, such as recurrent allergic rhinitis, which is a feature of upper respiratory tract infection, atopic asthma or bronchial asthma, which is lower respiratory tract, and atopic dermatitis. These all three are the triad of atopy. Now, talking about the pathogenesis, why the atopic dermatitis occurs, it is because of defective barrier function of skin. So basically, the skin got dried. There is flagrant mutation, filament aggregating protein. Also, there is marked Ig response to the allergens due to high levels of interleukin 4, 10, and 13, due to which also there is increased transepidermal water loss, as the skin is not functioning well and there is dry skin. So due to all this, there is a cycle of itch, scratch, itch cycle. So basically here the itch, itching precedes the scratching, and the scratching there is further positive feedback cycle. So the scratching does not relieve the itching, rather itching got aggravated by scratching. Now atopic dermatitis has three clinical phases: infantile, childhood, and adult. In infantile age, that is basically the age group up to, yeah, within 2 years, here the lesions are papillovesicular or exudative type. The sites include face, scalp, and extensor of extremities. Like the baby always use the extensors to crawl. Next is childhood phase, where the age is more than 2 years but up to within puberty age group. So the lesions are red, scaly, and excoriated papules. Plaques and lichenification can also be seen. The sides now change to flexor surface. Adult phase, that is beyond puberty, lichenification will be seen over the flexors. So the basic complications of the atopic dermatitis is bacterial infection like Staph aureus, viral infection like eczema herpeticum, or disseminated cutaneous herpes simplex virus 1 infection. And another most common complication includes the erythroderma or exfoliative dermatitis, where it involves more than 90% body surface area with erythema, which is with or without scaling. Now, the key diagnostic criteria, which is very important one, is proposed by Hanfin and Rajka. So it can be remembered by the mnemonic as बहुत ज़्यादा खुजली बहुत लंबे समय से परिवार वालों के साथ कुछ खास जगह पर. सो बहुत ज़्यादा खुजली, डेट इज़ प्लूराइटिक. बहुत लंबे समय से, डेट इज़ क्रोनिक. परिवार वालों के साथ, दैट इज़ फैमिली हिस्ट्री ऑफ एटोपी. एंड कुछ खास जगह पर, विच आई हैव ऑलरेडी एक्सप्लेन द डिस्ट्रीब्यूशन ऑफ लीजन्स. Like in infant, it includes extensor, face, flexor. In children, it includes flexor and face, while in adult, it is predominant on the flexural area. So these are four major criteria, and there are 23 minor criteria also. So, minor criteria includes the xerosis or dry skin, ichthyosis like fish-like scale, white dermographism, which is very important one, that is on stroking the skin, white line appears due to vasoconstriction. Normal skin we see on stroking give wheal flare appearance, while on this we see white dermographism. Also, in ophthalmic manifestation, we can see conical cornea, or also known as keratoconus, shield cataract or ASSC, that is anterior subcapsular cataract, infraorbital fold of skin, which is very important one, Denny Morgan fold, and lateral medrosis, Hartogge sign due to continuous rugging. So basically, these we need to know about this. Treatment includes of atopic dermatitis, it's topical like emollients and topical steroid. Emollients decreases the dryness of the skin, and topical steroid, as we know, steroids are anti-inflammatory. So ointments are given if lesions are liquefied like thick plaque, and cream for scaling and oozing acute and subacute eczema. For the systemic medications include systemic steroids and cyclosporin, which is calcineurin inhibitor. Side effects of cyclosporin includes hypertension and nephrotoxicity. Also, newer drugs are also there like crisaborole and dupilumab. Crisaborole is phosphodiesterase 4 inhibitor and is approved for mild to moderate atopic dermatitis, while dupilumab is anti-interleukin 4/13, which is approved for moderate to severe atopic dermatitis. So now, as we have covered the topic, now we will quickly see the images further. So eczema, basically the term comes from boiling, which is reference to tiny vesicles which are seen in early acute stages of the disorder. Dermatitis, on the other hand, means inflammation of skin. So strictly speaking, as I have already explained, it is a broader term than eczema. So this I have further explained, as you can see. So atopy I have already explained. So clinical features I have just mentioned: acute, subacute, and chronic eczema. Chronic include lichenification, like hyperpigmentation, thickening of skin, and exaggerated surface markings. Subacute I have already explained, scales and excoriation. And acute one includes the signs of acute inflammation like erythema, papule, vesicle, oozing, edema, etc. So three stages: infantile, childhood, and adult. Infantile I had already explained. There is extensal involvement due to crawling of baby. Face and elbows are also involved. Up to puberty, flexural involvement. Now these are the criteria which you have remembered by name: Hannifin and Rajka's criteria. There are 4 major and 23 minor criteria. Uh, Criteria I have already explained by mnemonic. Minor criteria are these one. Few important ones I have explained in detail. This is Danny Morgan fold picture, which is extra skin fold in lower eyelid. This you can appreciate by the picture. Now I have talked about complication also, like the skin infection like Staph aureus, which can cause folliculitis or impetigo. Herpes simplex virus, eczema, herpeticum I have already explained. Complication. Next, what you will advise to the patient or educate the patient to avoid alkali soap, as it is an irritant and cause irritant dermatitis. Also, there is food and wool intolerance in the minor criteria of Henkin and Rajka's criteria for atopic dermatitis. So you have to educate the patient. Also, emollient is given as a topical medication to decrease the dryness of skin. So treatment I have mentioned this here: education the patient, emollient to be given, topical steroid to be given, tacrolimus, and this I have already given. Explained. Causes of eczema can be both allergen and irritant. I have already explained, which are the exogenous factor and endogenous factors are also there. So these are acute and chronic eczema. So this is acute eczema. I have already explained. Picture. This is eczema with excoriation, crusting, etc. So these are the 3 pictures and 3 differences between them. So can you guess, guys, what is the image of these showing? So in the first image, it is due to hair dye, contact allergic dermatitis. Hair dye contains a chemical known as PPD, paraphenylenediamine. Second is also the same image, and third is also the same image. So upper 3 are showing the contact allergic dermatitis due to hair dye. Now the below picture is of the middle finger with the irritation due to ring. So it is due to artificial ornament injury, and I have already explained artificial ornament contains nickel. So it is basically due to exposure to allergen nickel, which is causing contact allergic dermatitis to this. Next picture is also showing a contact allergic dermatitis due to nickel allergy. Next picture is of a lady which is having contact allergic dermatitis due to bindi. Bindi contains PTBP, which is para tertiary butyl phenol, which is acting as an allergen here. So can you guess, guys, these images? So this is basically an image of irritant contact dermatitis. The irritant contact dermatitis, also known as housewife eczema, as I have already explained, is due to the exposure mainly to detergent and some vegetables. Here it is due to detergent. The pictures is showing. Limited to the contact area. Now further images. Further images is of, as you can see, guess it rightly, it is of endogenous dermatitis. First one, can you guess? Yes, it is nummular eczema. Second one, as you can see, the scaling, it is seborrheic dermatitis or dandruff. third one is due to scaling, as you can see. It is due to asteatotic eczema picture. Now next one is, you can see as a DVT picture. So chronic venous insufficiency, so it is stasis eczema. Now next one is atopic dermatitis picture. Above hand and all the areas, chronic relapsing inflammatory skin infection, as you can see. So basically it is a picture of atopic dermatitis. Here the skin is dry and xerosed, and basically the flexular area is involved in the adult. Also the face area is involved. So it is an adult, you can see. Now next is, you can guess rightly, as the plant grass, congress grass is also shown, which is which is Parthenium hysterophorus, and the causative allergen in airborne contact dermatitis is sequestrin lactone. Here the dermatitis, as you can see, is over the exposed part areas, mainly the neck, upper eyelid, face, and V area of chest. Now for Hannifin and Raska diagnostic criteria, I have got an important image where you can remember all by a mnemonic: chip, bakes, drip. So you can slow the video and you can remember it, I hope. And that's the last topic, which is picture showing patch test, which is a diagnostic test for contact allergic dermatitis. As you can see, there are two readings are basically taken on second day and fourth day, that is on 48 and 96 hours, and more specific is fourth day reading. So if the patient, a small quantity is placed of allergen is placed in the fill-in chambers, as you can see, and uh, which is over the back of patient, and if the patient comes positive for that particular allergen, it confirms the diagnostic or patch test. But as you can see, the photo patch test is a diagnostic feature of airborne contact dermatitis. So I have finished the slide, and I hope that you like my presentation. I have tried to cover the important topics in a short period of time. Basically, it's a vast topic, but I hope I had been able to explain you guys well. Hope you like my video. Please share and subscribe. Thank you guys.